Good afternoon. We're going to start the House Commerce Committee hearing. We're just waiting on a quorum, but I do want to get our meeting started. We've got a big day ahead of us and want to be respectful of everybody's time. Just a roadmap for the day. We are going to take up 3 bills before the end of our scheduled end time at 4. So House File 90, House File 1340, and House File 766. We will, my intention is that we will hear testimony, vote on all of those bills. We will then recess and reconvene at 7 p.m. to take up House File 12. And the reconvening will be here in this room. We're expecting a large crowd, and so the sergeant's office has distributed tickets to get into the room, and overflow seating will be available in room 181. Just wanted everybody to have that roadmap for today. We don't have a quorum yet, so we can't take up minutes, but I would like Representative Schultz to begin by introducing her bill, and we will have official action on that bill once we get our quorum in place. Representative Schultz, to your bill.
Thank you, Madam Chair and members. This is House File 90, which I'm calling the Elder Care Bill. This is the 4th committee stop for the bill. So I would just, I'm going to briefly go through what I think is relevant to the Commerce Committee in this bill, since it's a rather large bill. So this is a response to the multitude of stories you've already heard about families who had experienced horrific and unthinkable abuse of older and vulnerable adults living in assisted living establishments and nursing homes. The bill before you seeks to address the problem of elder abuse in a systematic, multifaceted way. And for today's hearing, I'm going to focus on sections in House File 90 that are within the jurisdiction of this committee. First, Article 1, Section 2, starting on line 4.23, governs contracts between assisted living facilities and residents. It establishes a single contract for housing and services, addressing a major point of confusion under today's system. Second, on page 9, line 1, the bill requires that all notices be provided in plain language and that accommodations be made for persons with communication disabilities. Beginning on page 9, line 8, the bill recodifies and strengthens the Bill of Rights for residents in assisted living. Among other things, it requires disclosure that the resident can contract with outside home care providers for services not provided by the assisted living facility, and reaffirms the right to file grievances about services received or not received. Turning to page 23, beginning on line 13, we address one of the most common and vexing problems we hear from older and vulnerable adults and their families: deceptive marketing. Over and over, we have heard that residents have been promised various services or promised that they will be taken care of throughout their aging process, only to be shocked by receiving a termination notice when they actually require the services they've been promised. Finally, being on page 29, line 22, the bill puts some guardrails in place regarding forced arbitration clauses. While banning them is preempted by federal law, among other things, the bill requires disclosure that they are in the contract and prohibit choice of law or venue provisions. And we do have an amendment, but you might want, I think we can open it up to testifiers if you want to do testifiers first.
Representative Schultz, we do have the quorum that we need, so I'm going to take care of a couple pieces of committee business quick. First of all, members, the minutes from March 8th. Is there a motion to approve the minutes?
So moved.
Representative Elkins moves approval of the minutes of March 8th, 2019. Any discussion? Seeing none. All those in favor say aye.
Aye.
Those opposed say no. The motion prevails. The amendment is adopted. Next, we will put House File 90 before us. I will move that House File 90 be re-referred to Ways and Means with a recommendation that it go to State Gov Finance. And I will move the A11-1 author's amendment. Is there any discussion to that amendment? Seeing none, all those in favor say aye. Aye. Those opposed say no. A motion prevails. Your amendment is adopted. The bill is in the shape that you would like, Representative, and happy to hear from testifiers. Ms. George, welcome. You can state your name for the committee and proceed.
Good afternoon. Madam Chair, members of the committee, my name is Mary Jo George with ARP Minnesota. I am here also testifying on behalf of Legal Aid and Elder Voice Family Advocates in support of House File 90. Preventing elder abuse is a top priority for our coalition, and we want to thank Representative Schultz for her leadership on this issue and the opportunity to testify this afternoon. And I'll just speak to the several provisions specific to the committee's jurisdiction. First, as Representative Schultz said, the bill creates a single contract for both housing and home care services, creating one accountable entity for the care of a resident. This addresses a serious problem we have today in that the care is often fragmented when it is delivered by two separate entities. This can cause confusion and undue harm to elderly residents when there is not one responsible party accountable for the development of an individual care plan. So under the bill, residents and family members would now know who to go to regarding care quality concerns, and that the care would be provided in a very coordinated way. These are very important, Madam Chair. The bill also creates a number of disclosure requirements about residents' rights, information about who to call in cases of suspected maltreatment and abuse, and any of the arbitration agreements residents would be required to sign prior to move-in. Additionally, the bill does strengthen rights against retaliation for both residents in nursing homes and assisted living facilities. Lastly, the bill prohibits deceptive marketing by assisted living facilities. Unfortunately, we have heard of far too many stories of aggressive sales pitches and misleading tactics used by housing managers to get people to move into these facilities. I want to share with you briefly some stories. We have heard from more than several family members who have told us that the daily wellness checks were told that the daily wellness checks were part of their service contract, only to find out that the facility did not have a system in place after discovering their parents had died alone and were left for days without anyone checking on them. For residents with Alzheimer's disease, there have been reoccurring problems with deceptive marketing. For Eric Lien and his mother, who was diagnosed with Alzheimer's disease, his experience was nothing short of a nightmare. He was promised quality care from 3 facilities, but they failed to provide even basic care. They assured him they had security measures, but his mom was able to leave the facility unattended. Eventually, she was discharged with only 24 hours notice and evicted from her home without any assistance from the facility. For Laura Edstrom, her mom too was promised quality programming, including being escorted to dinner because she was often confused by the long hallways. But instead, her mother was constantly lost in these hallways, and the programming for residents with dementia consisted of being locked in a room with a television for the whole night. Finally, I just want to share my own perspective on deceptive marketing because our family experienced this too. After my dad's hospitalization, we had transferred him to a nursing home for a short-term stay for rehabilitation. At the time, we were considering moving him to the assisted living that was attached with the nursing home. But after several months, he did recover, and so he wanted to go home, and we were going to get home care for him. So we let the marketing manager know that we were no longer interested in this apartment. Her response surprised us. She said, if your dad doesn't move into this facility against our advice, then Medicare will consider your dad AWOL, and our family would be on the hook for the 100-day nursing home stay. Luckily for me, I knew a thing or two about Medicare rules, but I am very concerned about the many unsuspecting families that may not know and could have been very intimidated by her remarks. So again, under this bill, these types of marketing practices would be prohibited and enforceable under the law, which is really key. In conclusion, we do believe these provisions will go a long way in protecting vulnerable adults and their families, and we urge your support. Thank you.
Thank you, Ms. George. Next testifier, I see Carrie Thurlow or Toby Pearson. Welcome. said or, but we'll make it and. You can
Madam Chair, we're a tag team.
You can introduce yourself for the record and proceed with your testimony.
Thank you, Madam Chair and members of the committee. My name is Carrie Thurlow. I'm the Senior Vice President of Advocacy for Leading Age Minnesota, here also on behalf of the Long-Term Care Imperative. I want to start by acknowledging the stories of harm and abuse that we've heard in the news and with family members throughout this process, and want to acknowledge that they are terrible, they're intolerable. And I think that it's fair to say that in the course of the interim and throughout the fall, since the legislature adjourned last year, we've made tremendous progress in coming together as a stakeholder community, providers, consumers, regulators, and payers to further discuss the solutions that are needed to many of the issues. I want to thank Commissioner Malcolm and the Department of Health for doing the hard work over the interim to bring stakeholders together to address these issues. The long-term care imperative fully participated in those work groups. And we found that, as we long suspected, we have more in common than we separate on these important issues with regard to solutions to the many issues that this legislation attempts to address. As my colleague will say, I get to play good cop here, and then we do still have some concerns with the bill as it continues to move, and know that this is a work in progress as we remain committed to working on these issues. I want to say that the work groups over the fall and the winter identified a set of common principles and emerging areas of consensus that should guide these discussions. And I think it's important to have that touchstone. First, I think there's large agreement that it's important to maintain choice and flexibility in assisted living. Recognizing that we start where Minnesota is nationally recognized for promoting choice and flexibility. We have been ranked by groups including AARP as number 1 or number 2 in the country. And it's important to note that these are not institutions, but rather home and community-based services. And we are not seeking here in this legislation to create more nursing homes. The second kind of core principle are that seniors should be able to live as independently as long as they are able, with access to safe, quality care options in the communities that they call home. That is an important element here as well. So on one hand, we're talking about choice, but we are also talking about independence and safety as well. Third, that there are many perspectives that need to be considered as we work together to ensure a system that that balances the values of independence and choice with the desire for safety and protection. Fourth, whatever law is passed, we need to ensure there are adequate resources for implementation and enforcement. Many of the issues that we have heard have grown out of violations of current regulations, and so any new regulations must also include clear enforcement mechanisms. And fifth, last but not least, prevention should be a key focus of our work. We know that, especially in this committee, we're focused on a few key items, and I'm cognizant of that. But we should ensure that there is an infrastructure in place to help use data collected to help inform prevention and quality improvement efforts that should be included in the legislation this year. To be clear, the long-term care imperative supports assisted living licensure with specific criteria for evaluation, disclosure, and service termination. We support increased dementia care standards. We support language establishing the right to electronic monitoring. We support strengthened protections for consumers against retaliation and deceptive marketing.
We're trying to keep everybody to 2 minutes.
Thank you,
so
Mr.
I think
Chair.
you're beyond that now.
Thank you, Mr. Chair. I'll turn it over to my colleague to specifically address key
You
concerns.
don't want me to go back to the way I was this morning.
Heard about that.
I'll take your word for it, Mr. Chair. Thank you.
I was crappy this morning. I apologize to Representative Haley already.
Mr. Chair, members, my name is Toby Pearson with Care Providers of Minnesota, today with the Long-Term Care Imperative. First, as we have said, we support many of the things that are moving in this assisted living licensure bill, but there are a couple details that really matter and that we cannot support in its current form. Specific to this particular legislation in this committee, there are overly broad definitions of deceptive marketing and retaliation contained in our opinion. Providers are not opposed to greater protections for either of these issues, but the language appears to be overly broad. For example, With respect to deceptive marketing, it would apply to any misleading statement or representations by any employee. Recollections of verbal interactions are not reliable, which is why written contracts are utilized. Additionally, there are numerous existing state laws for consumer protections from deceptive marketing, including laws prohibiting false advertising and deceptive trade practices. With respect to retaliation, the language would apply to acts against a resident, employee, or person with a familial, personal, legal, or professional relationship with the patient or resident, which is an overly broad universe of folks for that to apply to. Under the language, the provider is presumed guilty of retaliation for any long list of actions taken within 90 days of an initial complaint, and this would include increase in necessary services if the resident's condition changed, the discharge of a resident if their care needs exceeded the provider's ability to administer said care, and would even potentially prevent the termination or discipline of an employee who self-reported a maltreatment incident. The lengthy list of retaliations does not take into account the frequent changes in service needs for senior population served in these settings. Several of the actions considered retaliatory could actually put seniors at greater risk for maltreatment. On the single contract topic, we think that it makes sense to move towards a single contract with one accountable entity. We have concerns with the scope and the enforcement of the Bill of Rights that is currently in this bill. And on forced arbitration clauses, we just want to make sure that there's the availability that if the parties want to enter into a separate arbitration agreement, that would also be allowable. Thank you.
Thank you. And, well, I shouldn't make a comment, but I've never seen a low-income person or a worker win an arbitration. So we should be worried about that. Next on the agenda here is, that's it? All right. Any other public testifiers? Anyone else wants to testify about this bill? I'm going to say it one more time, and then we're going to move on. Anyone else want to testify on this bill? Good. Member discussion. Representative O'Driscoll.
Thank you, Mr. Chair. And Representative Schultz, thank you for taking this cause. As we know, this is a multiple-prong problem, and it's going to need a multifaceted solution to this. And many things were discussed today, and I wish you well with your continued efforts on this. And I know that you don't want to, you want what's best in the end on this, and we also, as other members of the legislature, and people who have parents who are going to be involved in this, or grandparents, or other family members, we also want to have the right outcome on this. So I wish you well as you continue on with this, and keep working with the stakeholders, because I think you'll get there. Thank you, Representative.
Any other discussion? Any other discussion? Representative Tice.
Thank you, Mr. Chair, and Representative Schultz. Having been on Aging and Long-Term Care Committee for several years and being vice chair last year, I'm obviously quite up to date on a lot of the things that are happening. What concerns me, though, is that when we had the Office of Legislative Audit bring back their report, and we're hearing a lot about OHFC and how reports increased, there weren't enough people to take care of it, they didn't have confidence in the folks that were there, and investigation timelines weren't met, things like that. My question is, what does your bill do to make sure that that group is, that OHFC is held a little bit more in check, and in fact that they are doing their job?
Representative Schultz.
I think the agency might want to respond to that. Or Ron. Here we go. Yes.
Welcome to the committee, and identify yourself for the tape.
My name is Marie Dotseth, and I'm an assistant commissioner at the Minnesota Department of Health. And Representative, you ask a good question about what we've been doing, and I think we are happy to provide you with updates in terms of our investigative timelines and data. We publish a public dashboard now that shows all of the information on the number of reports that are coming in and the number that we close. We were publishing information on the number of substantiated reports, and we put that up weekly on our dashboard. So there's a number of things that we're doing, and I think when Commissioner Malcolm has come and presented to either the House or the Senate she mentions that we still have a long way to go. We've implemented a number of improvements and have published a number of data to put out there to the public, but we know we still have a long way to go in some of those improvements. And we're happy to come anytime you would like us to come and present you with updates on all of those OLA findings.
Representative Faith.
Thank you, Mr. Chair, and I'm not sure who wants to take this, but what I'm asking is there anything in this bill that addresses those concerns and those findings?
Yes, Representative, Mr. Chair and Representative, there are a number of items in the governor's budget that do address this. Thank you, Representative Schultz, for reminding me. There are several parts of the governor's budget that address those findings directly.
And
Okay, Mr.
Representative
Chair,
Faith.
I guess I'm hearing, no, there isn't. We're relying on the governor to do this, and I'm really concerned because that was a large part of what was happening is the OHFC was not doing their job, and yet we're looking at pointing fingers at just about everybody else but the agency. And I just want to make sure that we do have some safeguards in place to make sure that the agency knows that they are largely responsible for what happened, and what are we doing to make sure that it doesn't happen again. When I see things like there was no confidence in leadership and such, that's really discouraging. And we can make all the laws we want, but if we don't look at the agency where basically the buck should stop here, I'm not sure that doing a lot of other good stuff is going to cover up what really needs to happen. And those are my concerns with the bill. I don't feel like we're addressing where the problem lied, and we're looking at some other means to take care of things. I really hope we can address those concerns as we go on, but I don't see us doing those things right now. Thank you.
Can I ask a question before you respond, or would you like to respond first?
No, go ahead.
Has the agency had, over the 4 or 5 or 6 years that this built up, how many times did the agency just say, oh, we don't need another staff person, we'll just absorb that cost? I guess my question is, did you have the staff to do this kind of inspections of long-term care facilities?
Mr. Chair, I think what we realized happened over time is that the volume of complaints increased very rapidly. And so, I mean, there were a number of factors that led to that coming together all at one time. And, you know, as things changed, as the aging population grew, as the MARC reporting system made it easier for reports to come in, we found ourselves falling behind. And we did a number of things over the past several years to make sure that that's not happening anymore.
And did you ask for the staff at the time?
I've only been at the agency for a little over a year. I understand, yes, we have asked for some, and...
No, I meant at the time that you realized, did you ask for the staff? And if you weren't there, unless you could bring somebody forward who was, that's fine. Representative Schultz, you wanted to respond.
Sure. Thank you, Mr. Chair. This is going to require more than just this one piece of legislation. The agency had to act. They could not wait for legislation, so they had to act quickly to resolve those issues, to process claims and investigate. So they did, and we've had Commissioner Malcolm at the Long-Term Care Division multiple times to talk about these issues. So that committee, I think, has felt that they've been informed about how that process was handled and how everything has been rectified in terms of slow processes of claims and follow-up and investigation. But this bill we need to pass this legislation to give more power to have more oversight and regulation to prevent these types of abuses from ever happening. So I think this is one of the key pieces of legislation we need, but also to fund the agencies and the Ombudsman's Office for Long-Term Care, so they can also help. And that's a separate bill as well, as to fund the Ombudsman's Office for Long-Term Care, so we can be more active with people on the ground to follow up with investigations and file reports and provide education and information to family members.
Members, is there any other discussion to this? We have one person that wants to testify. I just realized this is a Commerce Committee, and it seemed like we were getting a little off there. So if I could ask staff to kind of what pieces of this bill should the Commerce Committee to address?
Mr. Chair and members, we're focusing primarily on Article 1 issues involving deceptive marketing practices, contract requirements, and disclosure requirements.
Thank you. If you'd like to testify, ma'am? Please identify yourself for the tape.
Hi, my name is Sheila Van Pelt, and my questions don't pertain exactly to those, but they were in direct response to your questions and to Representative Keel's. So from there, I can address or change
I
for
think
another
neither
time.
of those, neither of those were in the preview of the Commerce Committee. So thank you.
So, thank you so much.
Any other discussion or questions for the author? I don't know who made the first motion, but I'm seeing no other discussion. I'm going to renew the motion to re-refer House File 90 as amended to the Ways and Means Committee with a recommendation to be referred to State Government Finance Division. All those in favor? Aye. Aye. All those opposed? I think you're on your way.
Thank you, Chair, and thank you, members.
Next on the agenda. Lien? House File 1340, Representative Lien. All right, going once, going twice, you don't see the guy? Edelson? We're going to go to Edelson. House File 766. You can go through time. Welcome to the committee. I will move House File 766 to be re-referred to Ways and Means with a recommendation to be re-referred to House File HHS Finance. Did I say that right? All right. Welcome to Commerce.
Thank you, Chair. Hello, members. I will keep this brief. This is an expansion of medical marijuana in the state of Minnesota. I will draw your attention to 3 areas of the bill. 4.16 through 4.20 deals with specifically with adding dispensaries to the state. There's currently 8 allowable. This would allow for 1 additional one per congressional district to be added. And that's 4.16 to 4.20. The second area would be 6.4 to 6.7. Manufacturers would be able to sell products to the other manufacturers. So we have MinMed and Leafline for the 2 manufacturers. Both, just so you know, members, that we do have representatives from both of those organizations here today. And then the other one, and I have it on my amendment, and I'm not sure where it would be in members. It was added as an amendment in the last committee, but the third piece that we're adding is the sale of industrial hemp to manufacturers that I believe would be in the purview of this committee. So those would be the 3 areas. And I'm happy to take questions.
If all those amendments had been adopted in the last bill, I think we have public testimony. Do you have a testifier or 2? Please identify yourself for the tape and proceed.
Mr. Chair, members of the committee, my name is Brandon Borges, and I'm here to testify in support of this bill. I'm the board chair of Sensible Change Minnesota. We are the policy arm of Sensible Minnesota. We've been helping patients with the medical cannabis bill since its inception in 2014. We've worked with over 500 patients and host a patient group of around 700 patients, and have also successfully commissioned the Commissioner of Health for the addition of traumatic stress disorder, autism spectrum disorder, and Alzheimer's disease. So first off, I would really like to thank Representative Edelson and all her hard work in making this step forward. We do believe that this will be a step to bring patients more affordable medicine. Medical cannabis is hard to access. It's also very difficult to afford for our patients. We have low patient numbers in Minnesota, and products that sometimes cost up to 4 times the equivalent in other states. As of last Friday, there were 15,000 some patients enrolled in the program. In comparison, New York and Pennsylvania, who have adopted our model, have around 100,000 patients each. Adjusted for population, that puts them at nearly 30 and 40,000 respectively. Patient access model like Arizona, for example, serves around 150,000 patients, or the equivalent. In addition, some of these other problems that we've been seeing coming up is that over 7,000 of these patients have dropped their enrollment due to costs and other reasons. According to the January medical cannabis program update from the Office of Medical Cannabis, fewer than 11,000 of these patients enrolled have actually made a purchase from the registered state manufacturers. So while our medical cannabis program ranks as a C- through Americans for Safe Access, this is a national watchdog group for medical cannabis program, that ranks actually slowly getting better in Minnesota, and we believe that this is a step in the right direction. Giving manufacturers the ability to wholesale their products to each other will give patients options to be able to purchase different medicines from the 2 manufacturers. Currently, we have patients going between both of them. As well as the addition of new patient centers. We have patients that drive 4 or 5 hours one way to get a 30-day supply. It's very difficult for them. As the last piece of this we are concerned about would be the addition of these new patient centers and maybe the overhead costs being passed on to patients. But we do hope that by allowing the manufacturers to purchase hemp products and CBD from local Minnesota farmers, that may offset that cost. So don't get me wrong, members of the committee, we have a long way to go, but this bill is a step in the right direction for our patients. So we're committed to working with all of you, and we want to improve access and affordability for patients that are not served by our program currently. So thank you for your time, and thank you again, Representative Edelson.
Thank you. Members, I'm informed that this is not the correct engrossment of this particular bill.
I was going to say, I don't think it is.
We're having them printed at the present time, and they'll be here as soon as they're done. So, do you have any other
No, Chair, I do not. I was just going to walk through and just let you know in terms of the dispensaries, I think that it will be about patient access. The second piece about addressing the manufacturers being able to sell to one another, I think will help with innovation of, there are 2 different companies that are.
Why don't you wait a minute?
Oh, yeah.
I think we have another testifier. And
Oh, is there? Okay.
Doing your closing remarks, it's best to do them after the testifiers. Good afternoon. Please identify yourself for the tape and proceed.
Good afternoon, Mr. Chairman, committee members. My name is Paul Johnson. I'm with the Minnesota Campaign for Full Legalization. I come before you today to talk about some of the money issues with this program. And I just want to bring the Pioneer Press from this weekend, and I hope you all saw it. We've been saying for 5 years this program is not working. People cannot financially afford it. It's an access issue. The patients have been asking for years to address this. There is enough activity happening in the state of Minnesota that we have the Minnesota Workers' Comp Program paying for the medical cannabis program for their patients, but people that are seen through Health and Human Services programs can't receive those funds. We've been hearing the patients on the price of this product, that it will come down if we can get more patients involved in the program. Through the SSI program, the federal program, there's over 98,000 Minnesotans that are involved with that. Just by pure definition of being in that program, they qualify for the use of medical cannabis under Minnesota statute, but none of them can afford it. I don't agree with the appropriations going to dispensaries and manufacturings to say that that's going to make patient access. There has been no money put into patient access for us to get our medicine. If this was insulin, we wouldn't even be having this conversation. It would have been done 4 years ago. So I am asking everybody to step up and say, no, we need to address these issues because these are real issues and it's going to continue to get in the way of the problem of this program. And we are spending far too much money for ancillary services and not addressing the reason why this program started, and that was to address the sickest of the sick. Thank you.
Thank you. Any other discussion? Any other persons that care to speak to this particular bill? We're going to move to discussion. Everybody keeps pointing to you. I'm going to get to you, but I'm trying to. Okay, everybody, just point at Dean. Representative Dean. Be careful with your finger.
Thank you, Mr. Chair. And my question would be for either the author or the testifier. We know that the number of patients is pretty low in Minnesota, and I'm wondering if the bill or if part of the issue is physicians licensing individuals for medical cannabis, because I know that when we first started the program, that was a real concern that not too many physicians were actually engaged in the process of licensing individuals for medical cannabis use. And I'm curious if that's changed over the past few years. If you could address that, that would be great.
Sorry, I'm going to phone one of my people here.
Good afternoon. Please identify yourself for the tape and proceed.
Hello, Mr. Chair, members of the committee. My name is Bill Parker. I'm the CEO of Lien, one of the two manufacturers. To your question, Representative, we're not seeing a shortage of qualifying physicians to certify patients. I think the last number I saw was around 1,500 are currently registered.
Okay, so thank you, Mr. Chair. So 1,500 physicians registered, then creating 15,000 people in the state of Minnesota, while other states have over 100,000. So I'm curious if it's an issue of numbers of people in the state. I mean, there seems to be a number sort of differentiation that doesn't seem to make sense right now. And I'm curious if people are trying to dig into that as well, because it seems to be, the numbers don't seem to make sense.
Chair, when this program, freshman rep coming into this, when this program was created in 2014, it was created as one of the most restrictive programs in the United States. And so what I think in terms of, I apologize, I didn't get your name, but when he came up to testify about the cost, it is a burden. The cost is one of the largest things that I've heard about when taking up this bill. This bill does go to chip away at that. Now, it's not going to move the needle enough, but we don't know. I do think that the cost is prohibitive for many people. Having medical marijuana in the state of Minnesota, honestly, is a privilege. Insurance does not cover it. I think that we're about 11,000 people in the state of Minnesota are using, which other states that don't have such a restrictive program have many more participants. So I would like to go into that more, and I think we're going to revisit and see how the things in this bill actually do for cost. I mean, one of the things that's not in my bill, but both of these companies were not allowed to deduct their business expenses. So in terms of also appropriations were addressed. The only appropriation that's happening on this bill is to the Office of Medical Marijuana, which is going to help with patient calls and things like that. So there's no other appropriation that's happening on this bill, and that's collected from fees that people pay. So hopefully that answers some of your question, Representative Dean.
Mr. Chair, it answers some of my questions, and I know that when we instituted it was most restrictive in the state, but over the past several years, Department of Health has begun to expand what are the medical conditions in which it can be used. So I'm assuming that the number of people that have the opportunity to be registered for medical cannabis has increased greatly. And the question is, are they not? I mean, I like what your bill does, don't get me wrong, but I think there's a larger issue, and yeah, I'll just leave it at that.
Representative O'Driscoll.
Oh, Mr. Chair, I just have a procedural question, and you can take it whenever you want. It just has to do with, are we maybe getting the proper engrossment copied into the committee? Is that our plan? Okay, that's all I was looking for. Thank you.
Representative David.
Well, thank you, Mr. Chair, and I'd be remiss if I didn't clarify something here that needs to be said. And I do this in every committee every time that a person says this. We just had a member of this legislature say, in effect, well, it's because I'm a freshman. You're a member of the legislature. That's the way it is. So you don't have to say that because we can tell. It's quite obvious. So please don't say that. You are a member of this House. Act like it.
This from the member that one time told me he wasn't going to remember my name until I won my second election.
Mr. Chairman, I'm of the opinion that freshmen will be seen and not heard.
Mr. Chair, I definitely am heard. So,
thank you, Representative Davids. Thank you, Representative Edelson. Is there any other discussion? Any other discussion? We are going to wait on the engrossment, and then we are going to move that. Yeah, our copying machine seems to be running a little slow. I'm going to lay this bill over. You'll have to sit here for a little while longer. Representative Lien.
Lay it on the table or lay it over?
Welcome to the committee, Representative Lien. Let's see, which bill is this one right here? I'll move your bill for you. I'm going to move House File 90 as 1340 for re-referral to the Health and Human Services Policy Amendment. Do you have an amendment for this bill?
Yes, Mr. Chair.
Thank you. Please proceed.
Thank you, Mr. Chair. Committee members, I appreciate you hearing this bill today, House File 1340. And just a little bit of a background on this bill. The first mental health and substance use disorder parity bill was passed in '96, and a second bill was passed in 2008, which substantially strengthened the mental health parity standards. The regulations went into effect on January 13, 2014. Mental health parity has consistently been a bipartisan issue, with Congressman Ramstad and Senator Wellstone, both serving as key advocates at the federal level. The law and accompanying federal regulations require health plans to cover mental health and substance use disorders as they do for physical health care if the plan covers mental health or substance use disorder treatment. Minnesota law incorporates the federal mental health parity requirements. There are three components of the mental health and substance use disorder parity law: out-of-pocket costs, arbitrary treatment limits, and non-quantitative treatment limits. Health plans cannot have higher out-of-pocket costs for mental health care or substance use disorder than other forms of health care. This means that, with a few exceptions, copays for mental health care or substance use disorder cannot be higher than for physical health care, and there cannot be different deductibles or out-of-pocket maximums for mental health care and substance use disorder. Health plans cannot set arbitrary treatment limits for mental health care. For example, a health plan cannot offer unlimited primary care appointments, but only 3 mental health therapy appointments. Non-quantitative treatment limits are tools a health plan uses to manage their benefit set. Mental health parity stipulates that the standards that a health plan uses to determine the benefits for mental health and substance use disorder treatment cannot be any more stringent or restrictive than it is for other categories of health care. For example, many plans cover rehab in a nursing home after hip replacement, but would not cover rehab in an intensive residential treatment program, or an IRTS, for someone with a serious mental illness leaving the hospital. This would be a mental health parity violation. Other examples of mental health parity violations through the use of NQTLs, which again are non-quantitative treatment limits, include narrower networks for mental health and substance use disorder, using a more stringent process to approve new treatments for mental health or substance use disorder, or more restrictive use of prior authorization requirements to obtain treatment. To ensure compliance with federal parity regulations, health plans must already document the strategies and processes that led to the determination of a NQTL for both mental health and other forms of health treatment. Now, there are grave consequences for patients and families for failing to meet the mental health parity. Some of these include unique burdens, such as having to call to get permission for mental health care, but not other types of care, restrictive drug formularies that make it harder to access necessary medications, higher copays, deductibles, and coinsurance rates that deter accessing mental health treatment, denials of care due to an arbitrary standard of what is deemed medical necessity, limiting in-network mental health providers, making it more difficult to receive care, and lack of coverage for residential treatment or intensive home care. If current mental health parity laws are enforced, more Minnesotans will be able to access the mental health and substance use disorder treatment they need, and the outcomes will be more positive in the long run. In late 2017, NAMI National released its third nationwide parity report called The Doctor Is Out. The report found that despite the federal parity law, people lack the same access to mental health providers as they have for other medical providers. For example, 34% with private insurance had difficulty finding a mental health therapist, compared to only 13% reporting difficulty finding a medical specialist. And when people did find a mental health provider, many were forced to go out of network and, by extension, pay higher out-of-pocket costs. This happened at much higher rates than when seeking primary or even specialty medical care. 28% receiving mental health therapy used an out-of-network therapist, compared to only 7% needing to use out-of-network medical specialists. A report from Milliman that same year also found higher use of out-of-network providers for mental health and substance use disorder treatment, and a pattern of stark differences in payment rates for mental health providers across 50 states, 3 years and 42 million lives. And at this time, Mr. Chair, I can speak to the amendment. The A19-0126 Authors Amendment would change the title of the bill and delete Section 1 and 2 of the bill, which eliminates redundant language in consideration of existing federal law, and the language in Section 3 of the bill for NQTLs, which again are non-quantitative treatment limits. The amendment also changes Section 4 of the bill as follows. It allows the Commissioner of Commerce to require data from health plans that mental health parity is being followed. It ensures that mental health care is considered primary care for the purposes of patient cost-sharing requirements, and requires the Commissioner of Commerce, in consultation with the Commissioner of Health, to report to the legislature annually beginning January 1, 2021 on state enforcement of mental health parity laws, rather than mandating this reporting from the health plans. We can now take up the amendment, Mr. Chair, if you like.
I try to lean towards the author, so if you're ready to get the bill in the order that you would like it with your amendment?
Yes.
Do you only have one?
I only have one, yes.
Okay. And that would be the 0126?
0126, yes, Mr. Chair.
I don't have to worry about that one, do I? No. All right, let me get rid of it. I will move the A19-0126. And you've explained that particular amendment. Are there any questions on the amendment? Any questions on the amendment? Any testimony to the amendment? Seeing none, all those in favor of the A19 amendment, the author's amendment, signify by saying aye. Aye. Opposed, same sign. The bill is in the way that you like.
All right. Thank you, Mr. Chair, committee members. And now to speak to the bill, despite federal and state law, mental health parity is still not being enforced because we rely on consumer complaints to identify parity violations. No one in the midst of a mental health crisis thinks to call the Department of Commerce or the U.S. Department of Labor. We need to strengthen the ability of the Departments of Health and Commerce to enforce current law. And just to speak to the bill here, it defines NQTLs, which again are non-quantitative treatment limits, mirroring the definition in federal law and federal regulations. States that a health plan may not impose an NQTL with respect to mental health or substance use disorder treatment if the processes for determining this NQTL are more restrictive or stringent than those applied to medical or surgical benefits. It provides more accountability by giving the Department of Commerce and Health the authority to request the information from health plans to confirm that mental health parity is being fully implemented. This includes any data on the use of NQTLs like prior authorizations, network adequacy, provider credentialing and reimbursement, medical necessity, adoption of coverage for new treatments, wait times, drug formularies, out-of-pocket costs, claim denials, in-home services, rehabilitative services, and other data that may indicate a parity violation. It requires therapy visits and medication maintenance be considered primary care for the purposes of copays and deductibles that a plan enrollee must pay. It requires the Department of Commerce and the Department of Health to monitor the implementation of mental health parity to ensure that that healthcare plans are following mental health parity requirements. This can include market conduct examinations, and it requires an annual report by the Commissioner of Commerce to the legislature every year regarding their efforts to enforce parity law, including any enforcement actions taken. Again, increasing transparency and creating new enforcement mechanisms will lead to better and more long-term health care for Minnesotans and more equitable health care for all Minnesotans. Mr. Chair, committee members, at this time I can stand for questions or we can allow testifiers to make comments.
Why don't we go to your testifiers, and then we'll, if anyone cares to speak for or against the bill and from the public, we'll bring them down also. Please identify yourself for the tape and proceed.
Thank you, Mr. Chairman, members. Sue Abderholden, Executive Director of NAMI Minnesota, National Alliance on Mental Illness. You know, we finally begun to understand that our head is connected to the rest of our body and that good mental health is essential to overall health. 1 in 5 people will develop a mental illness during their lifetime, and that's a significant portion of the population. And yet a significant portion cannot obtain the treatment they need to get better. Parity doesn't even require coverage of mental health and substance use disorder. It just says if you do, then you need to treat it the same way. So you have to cover illnesses of the brain, such as depression or addiction, no more restrictively than illnesses of the body, such as diabetes. And parity really, I mean, all it really is about is, again, treating mental illness as any other healthcare condition. So the process that you use to determine new medications or treatments should be covered the same way. The drug formulary shouldn't be more restrictive. The in-network list of providers shouldn't be more limited. Plans shouldn't review mental health treatment more frequently to determine medical necessity. Plans shouldn't have more restrictive criteria to determine what is medically necessary. And this federal law, incorporated into Minnesota law, provided us with hope. Hope that we or our loved ones would have coverage for the treatment needed to recover. But I can tell you that the promise of parity has not been realized. My own family was impacted when our health plan wouldn't pay for the emergency room visit or the ambulance because it was a suicide attempt. There was a lesser percentage paid for the hospital bill and a very limited number of therapy visits. To say that my health plan discriminated against covering mental health treatment is an understatement. Many families like mine go into deep debt to pay for the care our loved ones need. Let me assure you, there are no bake sales or GoFundMe pages for mental health care. It's emptying our savings, charging treatment on credit cards, delaying retirement, and more. And it's not fair. We have a crisis in our state with an increasing number of people dying by suicide and an increasing number of people dying by opioid overdoses, and an increase in the prevalence of mental illness in children. If private insurance does not come to the table and follow the parity law, we will not stem these crises, and it will continue to get worse. Enforcing parity will save lives and state funding. Right now, when parity isn't enforced, people sign up for Medicaid. It's a cost shift. And the care is more expensive because care is delayed and denied until it reaches a crisis. Have you tried to see a psychiatrist or therapist, get into a hospital or residential treatment? You get to wait. And it's not just because there's a shortage of providers, it's because of narrow networks and low payment rates. There are providers wanting to be accepted into these networks because they know there are waiting lists, and the waiting lists are long and told, we're good, we have enough providers. Around the country, states and national organizations are looking at best practices for parity enforcement. All agree that prospective compliance verifications are necessary as long as there's also a retrospective review following a consumer complaint. We need to ensure ahead of time that plans are in fact following the law, and they need to provide information to verify that they are following the law. Now, the plans will tell you there have been few complaints, but again, when you're in the midst of a mental health crisis and the treatment your loved one needs won't be covered by insurance, you don't stop and think, I'll call the Department of Commerce, said no one ever. You shouldn't have to rely on complaints for enforcement. The department should review the plans ahead of time to make sure they are following the law. Last year, we agreed again for the second time to a task force to figure out how the plans would submit data. I want to say that initially it was a much greater analysis that was worked on by the National Parity Coalition that some states have adopted. So it was a huge spreadsheet that they would have to do and quite complicated. And we tried actually over 2 summers to say, well, what information could you provide? And we didn't get anything. And I'm going to be honest, we've waited a decade for enforcement, and we're not ready to wait any longer. The plans tell us that they are following parity. This means that they did their own analysis. We'll show the department that analysis. The data we placed in the bill, instead of the huge analysis, is data that they have. And it's data that will help the departments know if, in fact, they are following parity and treating mental health and substance use disorders the same as other healthcare conditions. Please provide the tools to the department to enforce existing law. Don't place the burden on people struggling with their mental illnesses or on families stretched to the max as they try to navigate the mental health system and the complexity of health plans. Our state got an F for parity enforcement, an F. We're not asking for new mandates. We're not asking for new coverage. All we're asking for is fairness. We just want the current law enforced. Thank you.
Thank you. Thank you for your testimony. I suspect you have another testifier, and it's my regret, or my failure is to have kept you to 2 minutes, so I'm going to try to keep you to 2 minutes, sir.
Thank you, Mr. Chair and members of the committee. My name is Jeff Christensen. I've lived in Lakeville for 16 years. I'm here today to speak about my son, Drew. Drew was diagnosed with bipolar II in the summer of 2014, after he had completed his 3rd year of studies in chemistry at the University of Minnesota. He took his lithium because it was element number 3 on the periodic table. He was studying to be a chemist. He understood what it did. But over time, his swings became more pronounced, making it a struggle for him to perform in his classes. He did finally receive his diploma after completing his studies in the spring of 2016, and soon after that, he landed a job as a contractor at 3M. In 2015, my wife Nancy and I attended a NAMI family-to-family course on mental illness. We learned a great deal about diagnoses and treatments, and we also learned about a community mental health organization in St. Paul called Guild Incorporated. I remember telling Nancy that I wish I had known about Guild when Drew was first diagnosed, because they offered care coordination, which assesses the kind of care someone needs and how to help them, and they had a range of services, including residential treatment. My wife and I longed for Drew to agree to therapy in addition to his meds and quarterly visits to the psychiatrist. He resisted, and there was no way that we could force this athletic and sometimes hot-tempered young man to go. His job at 3M lasted only a couple of months due to an outburst with his supervisor. I had hoped this would be the natural consequence that would persuade Drew to seek counseling, but he landed an even better job right away, assisting with research at Ecolab. He was a contractor again, but this time, this was a dream job with a path to full-time position. We don't know for sure, but we suspect that Drew stopped taking his meds once he landed his position at Ecolab. He was living at home with us during the summer of 2016, and his behavior became more erratic. He was using alcohol and marijuana to self-medicate. He got a DUI in early August and became threatening. Nancy and I had already been meeting with a social worker from Guild on a private pay basis because we needed someone to help us make a plan. We didn't know how to navigate the system to get the help that Drew needed. On September 11th, Drew became threatening again and we asked the Lakeville Police to help us. He was taken by ambulance to HCMC, where he spent about 10 days. We had insurance through my wife's company, and it paid the majority of Drew's hospitalization and about 50% of the $5,000 ambulance ride to the hospital. After his discharge, he returned home and discovered that he had lost his dream job. About a week later, he was hospitalized again, and this time was prescribed an additional medication to help suppress psychotic episodes. We knew he needed more services, maybe even residential, but it didn't appear that our insurance covered any of these things other than meds, hospitalization, and therapy, and he needed more. We went to the county to see what services we could get there. I took him to his psychiatry appointment, but the psychiatrist wasn't there that day. Apparently, they had tried to leave a message on Drew's cell phone, but he hadn't set up his voicemail yet before he had gone into the hospital. I took Drew to his first meeting with his therapist, and Drew said that he knew more than the therapist. I took him to the intake meetings at the county, and he started becoming discouraged again because of all the consent forms. He was a 25-year-old living at home with his parents, and these were all triggers that he didn't know how to handle. We had found an attorney who helped Drew get past his DUI, and he even got a provisional driver's license so that he could work catering jobs while trying to find another job in chemistry. He was discouraged because he recognized that he had a lot of work to do to reconcile relationships and pay people back for the expenses they had covered for him following his manic episodes. I often worked from home during this time, and we would go for walks, and that would help ease his anxiety. On Monday, November 7th, I reached out to the social worker at the county because I hadn't heard from her about next steps. She got back to me on the morning of November 8th to let me know that they were still trying to figure out whether Drew might qualify for Social Security disability or Medicaid. Medicaid would have covered the additional services he needed. That afternoon, we received a call from the Lakeville Police. They told us that the Minneapolis police confirmed that our son had died that morning. He had climbed the railing on a bridge. Someone stopped to ask if he was okay. He said no, and then stepped to his death. I honestly don't know what services our son might have benefited from, but I know with certainty that he needed more. My wife and I didn't know how to help him, and we desperately needed someone who could act as a quarterback so that we could return to being parents. When a loved one is diagnosed with a mental illness, you don't know what questions to ask. And yet, you somehow need to develop the expertise to know how to work the system to your loved one's advantage. And then there's HIPAA, a formidable defensive line meant to protect your loved one, except that it's really a roadblock at every turn. If someone has a cancer diagnosis, they typically don't put up a fuss about signing consent forms. But when someone is battling the unpredictability of bipolar, it's a lot harder to gain their consent just so that you can help them get the help that they need. I believe that my son could be alive today if the intensity of services provided by Guild had been available to us under our private insurance. Thank you, Mr. Chair and members of the committee.
Thank you. I and all of us are sorry for your loss. Is there another testifier?
Thank you, Mr. Chairman and members of the committee. My name is Kelly J., and I am the mother of Carter Schmidt. Carter's a brilliant, compassionate, funny 16-year-old that has lived with a mental illness since he was 7. The symptoms began with Carter pulling out 6 of his teeth that were not loose. He picked at his skin so much that the wounds wouldn't heal for months. We sought therapy for him, which began our journey into the mental health system. Over the years, all of his symptoms have escalated because he has not responded to outpatient treatment. And more often than not, he refuses to participate. Many times on the way to treatment, he jumped out of my moving car trying to escape the anxiety of going to therapy. In 6th grade, he had his first suicide attempt and his first hospitalization, which started the cycle we have been on in the years since. Ambulance, hospital, partial hospitalization, and which usually is cut off by the insurance company after 8 to 20 days, and then outpatient treatment, which he refuses. We have been on this cycle for years because Carter refuses outpatient treatment and the insurance company does not want to pay for the level of care that he needs. In November, Carter had a knife and was planning to use it to hurt himself. I was able to get the knife away from him, and while I was on the phone with the 911 operator, Carter removed the screen from our 2nd-story bedroom window and was headfirst out the window trying to jump. I caught him in time. I had to hold his hoodie sweatshirt and the belt loop of his pants to keep him from jumping headfirst out of our window. Carter was sent to the hospital in an ambulance. Per usual, there weren't any adolescent beds in the entire state of Minnesota. So he stayed in the emergency room in a locked concrete room with a bed and a television from Friday until Tuesday. No programming, no therapy. The hospital asked us several times if we just wanted to discharge him because there were no beds available. On Tuesday, he was moved to another hospital and was able to get treatment for 8 days in the hospital before the insurance company decided it was no longer medically necessary. He was stepped down to a partial hospitalization program, and I was very worried it was not a high enough level of care to keep him safe. Over the course of that month, he ran away from the treatment program several times. The last time, the Edina police had to be called to help find him. The police needed to be called several times in our home because he could not regulate his emotions, and he was destructive to property. It was determined that he needed a higher level of care and residential treatment was recommended. We found a program that was a locked facility and is typically a 3 to 6 month program focused on DBT skills and emotional regulation. With his history of running and refusing treatment, this was the best option for his care. I knew that Carter would refuse this option, so I planned a secured car to be at my home the morning of January 1st to drive him to the residential treatment program because I did not believe I could get him there safe with a history of jumping out of the car. Once Carter learned where he was going, he ran from home without a coat, and it was below zero. We had 5 police cars searching for Carter, and we were eventually able to get him into the secured car and admitted into residential treatment. We had several weeks of Carter not responding to treatment and his symptoms were worsening. On January 23rd in family therapy, he told us he was thinking about suicide all the time and he planned to pretend to be fine, but as soon as he was discharged, he planned to kill himself. He was put on 15-minute checks for the next week to make sure he was safe. A few days later, Carter started removing screws in his windows in his bedroom and started talking about escaping the locked facility. Thank you. The 15-minute checks were extended for 1 more week. Upon learning about the extension, Carter threw his chair at a locked door and began throwing his body at the door to try and break it so he could escape. January 31st, the day after this incident, Carter finally accepted that he was there and began responding to treatment. He told us he knew he needed to be there and he wanted to learn the skills so that he never had to go to a hospital again. He participated in school and therapy and began learning the DBT skills that they were teaching. February 7th, the day after his 2 weeks of 15-minute checks ended, 7 days after he started responding to treatment, we learned the insurance company was doing a review of his treatment and had only approved 4 more days. He was no longer in crisis and they were questioning whether the treatment was medically necessary. I called the patient advocate that works for the insurance company and pleaded with her to have her help us. We finally had a breakthrough and we needed him to be able to complete his program. I told her I feared for his safety and I did not believe I could keep him safe if he was sent home. February 15th, we learned that he was no longer covered by insurance and we needed to come pick him up. It was Friday and President's Day weekend. We did not have any services set up for his aftercare. His father and I decided to private pay for the weekend in the hope of setting up services for Carter when he got home. The insurance company denied our appeal. He was discharged on Tuesday with nothing in place. We are currently 3 weeks out from discharge, and Carter still does not have any aftercare services in place. We keep getting referrals to places that are either not covered by our insurance, have long waiting lists, can't take him because he's too acute, or would require him to be in a regular classroom. Since his discharge, Carter has run away from home twice. The first time it was in the middle of a blizzard, and he was wearing shorts and no coat. I followed him down the street in my slippers, also without a coat, while I was on the phone with 911. He ran away again on Sunday, no coat. We are frustrated because he was finally responding to treatment for the first time in 9 years. He was on phase 2 of a 4-phase program. He went from a locked facility with 24/7 staff to our home with no services. He needs a higher level of care, and we are unable to get it to him due to our insurance. We are terrified for his safety. Please support enforcing the parity laws. No family should have to go through what we are going through. Thank you.
Thank you. Thank you. Please identify yourself for the tape and proceed.
Mr. Chair, members of the committee, my name is Dr. Paul Gehring. I'm here today as a past president for the Minnesota Psychiatric Society, representing the almost 500 practicing psychiatrists in the state of Minnesota. I'm here to testify in favor of House File 1340. Both my background as a practicing psychiatrist of 27 years and in my role leading the mental health and addiction service line of the Line of Health have informed my passion for the parity issue. Over 10 years ago, the federal government passed a critical piece of legislation named the Mental Health, Parity and Addiction Equity Act of 2008, which requires equity and insurance coverage of mental health and substance use disorder care. However, years later, mental health parity is still not a reality. According to the National Milliman Report, and confirmed by many subsequent studies, access to care in Minnesota is not measuring up. This bill requires transparency and accountability on the part of insurers. This is necessary because numerous investigations have found that insurers are frequently out of compliance with the federal parity laws requirement that relate to non-quantitative treatment limit. These include practices such as prior authorization, step care, reimbursement rate setting, and provider network design, to name a few. Virtually every investigation has found problems in these areas. According to Milliman, there are unequal reimbursement rates for psychiatric payment practices. They're 40 to 59% lower for psychiatrists, and this is one of the highest rate disparities in the nation. Comparable services provided in primary care and psychiatry would yield $100 in primary care and $41 to $60 in psychiatry. These long-time funding discrepancies have underfunded our mental health and substance use treatment system and squeezed resources for our patients. Long wait times for initial clinic appointments and gaps in service openings happen all the time, and none of these challenges are new. Imagine similar gaps leading to a wait time of 2 or perhaps 4 weeks for in-network service if you had a kidney stone, or sitting in a hospital bed after a heart attack waiting 2 weeks for a post-acute rehab bed. In medical circumstances, there would be outrage and action. The Minnesota Psychiatric Society strongly supports mandated annual reporting by health plans to our regulating state agencies. Despite federal and state laws, mental health parity is still not being enforced. Information is the first step in starting to address this issue and into achieving better partnership between the state, payers, and providers. We don't have transparent data that tells us how far out of a line we are today. HF 1340 is a critical step in figuring that out so we can correct it for the benefit of those we serve. I want to thank Representative Lien for authoring this important legislation, and thank you for the opportunity to provide testimony. I'm available to answer any questions.
Thank you, sir. Matthew Schaefer?
Thank you, Mr. Chair, members of the committee. For the record, my name is Matt Schaefer. I'm the Government Relations Director for Medica, and today speaking on behalf of the Minnesota Council of Health Plans. I can empathize with what the other testifiers are going through. About 6 months before the mental health parity law went into effect, I had the privilege of writing a eulogy for a loved one as well. And frankly, it was the mental illness that took him away from us, and there's a relative that got to find the body, and it's not a fun place to be. Having said that, as we look at the bill in front of us, I want to begin by thanking Representative Lien and NAMI Minnesota for the amendment they brought forward. We believe it's a step in the right direction, and though we still would recommend going with a work group model for carrying out the intent of the bill. To give a little context on the type of coverage or how the law is implemented right now, every health plan in the state of Minnesota is required by law to submit any health insurance products that we wish to offer in Minnesota, as well as the Departments of Commerce and/or Health for review and approval. And through that process, each health plan must sign an attestation that we are offering products that treat medical expenses for a mental illness in the same manner which we would treat a medical or surgical procedure. In addition to that, we're in regular contact with regulators on a number of matters with respect to health insurance, to include ensuring that we're paying our members' medical bills, whether they're being treated for diabetes or depression. In addition, regulatory authorities have the authority to audit carriers to ensure we're operating in compliance with state and federal laws, and they do use that authority. The recommendation we would go for, though, is in addition to that, we're also waiting for guidance from federal regulators as well in terms of how we should respond to different requests for information. That's a rulemaking process that's still in effect, particularly with how the disclosure laws with ERISA interact with the mental health parity law regulations. That's something that we're hoping we'll get some new guidance on that. In addition, the National Association of Insurance Commissioners, the NAIC, is currently in the process of conducting its work on market conduct examinations for mental health parity, which means we're in the process of figuring out what they're looking for as regulators, and they're in the process of looking at our products and making sure that we're operating in compliance with the law. Instead of setting up a new set of reporting requirements, we would recommend going with a work group format, and one of the reasons for which is for the other states that have already passed this law, in the implementation phase, they've already figured out that they need a work group to figure out how they're going to put together this information in a way that is going to help patients and consumers. So with that, that concludes my remarks. I'm happy to answer any questions.
Are there any questions for the witnesses? Thank you for your testimony. Representative Lien? Representative Lien, you offered to answer any questions. Are there any questions from the members? Any questions from the members? Representative Davids, you have an amendment?
Thank you, Mr. Chairman. I'd like to move the H1340A1 amendment.
Would you care to explain your amendment?
Yes, thank you, Mr. Chairman. What this amendment does is this goes to what the health plans had talked about, what they would prefer. The bill, the way it is not supported by the health plans. In last year's omnibus bill that was vetoed by the governor, we had agreed to language between the mental health advocates and the plans to set up a working group to move this forward. As the testifier said, this really needs to be done. Now, if the Lien bill passes, these are the reporting requirements right here. Now, how does this help anybody that needs mental health crisis care? I don't know. This is what they have to do. Instead of giving care, they got to be filling out papers. Okay, this is just wrong. This is a very one-sided approach. It's heavy-handed. There's no buy-in. You have to have buy-in. We have to have a working group to put this together so you can come. I'll tell you what, you have a working group put this together. You come to the legislature, and I would guess that there'd be 0 no votes. I think it would pass through 100%. Without my amendment, this bill's going nowhere this year. I mean, that's quite obvious. And so do you want something that passes that gets the two sides together talking, or do you want to have another feel-good meeting and think you're doing something when you're not. Because that's what's going on.
Explaining your bill, your amendment?
Yes, that's what my amendment does. Okay, so it puts a working group together. We don't use a sledgehammer like this bill does. The plans to the amendment, well, first of all, this bill is not balanced as it is. It's not balanced. It's one-sided. It's heavy-handed. The plans already submit information to Commerce on their filings and need to attest to parity in their DHS contracts. They're already doing it. I think we've seen that the real problem here is the Department of Commerce. We have the laws. We can pass all the laws we want. We can put more laws on the books, and they're not enforcing it. Kelly J. said, please support enforcing the parity laws. Amen. I agree. Dr. Gearing said, mental health parity still not being enforced. The laws are on the books. They're there. Throwing another law, a heavy-handed law, making the health plans go through all this, doesn't help a thing. It doesn't help a thing. The laws are already there. I think we need to talk to the Department of Commerce and say, why aren't you enforcing the laws that are already there? That's my question. Is the laws are there, why aren't they being enforced? That's my question.
Did you want me to bring down the Department of Commerce to answer that particular question?
Yes.
Certainly.
Thank you.
Mr. Chairman, if I might, the original bill required that type of reporting, not as amended.
Why don't we wait till we get this question, and then if you'd like to speak.
Mr. Chair, for the record, Peter Brickwoody, Assistant Commissioner at the Commerce Department. Representative Davids, the Commerce and Health Department both share regulatory responsibilities related to enforcing parity statutes here in Minnesota, both the state and federal parity requirements. I don't have a comprehensive list of our activities thus far, although we could put one together for you. But suffice it to say, we have been engaged in this issue, and I think NAMI and the health plans could verify that for you. I think one of the potential concerns with a task force approach would be that we have been engaged on an individual plan-by-plan basis with our colleagues at the health department to have discussions with the plans about what is actually being reported and what analyses the plans are actually doing, which occurs prior to them submitting information to the department during the rate review process. Those conversations have been cordial, they've been productive, and they are ongoing. I think our concern is if you put together a task force, you will not be able to have that level of conversation on an individual plan-by-plan basis because the plans will not be able to speak candidly in front of their competitors about what's actually happening in each individual setting. So I think, Mr. Chairman and Representative Davids, I understand the approach that you are advocating here, and typically, that sort of let's get in a room together and figure out the solution. I agree is oftentimes something that we do around here, but in this particular case, I don't think it would actually be as productive as it would be to pass the underlying bill. And Mr. Chairman, if I might as well, I think one of the things in the delete all amendment that we have found is that there is an opaqueness to this issue. An opaqueness to this issue of non-quantitative treatment limitations. And so having some additional reporting requirements there based on data that I think the plans are typically already collecting, I think would be helpful to the departments in our analysis of whether or not plans that are filed with the department are meeting the parity requirements as they're being attested to in the filings.
And Representative Davids, if I might, if we pass this bill without your amendment, might the patients actually be on an equal footing with the insurance companies?
Well, Mr. Chairman, they already are.
They certainly don't seem to be. When somebody has 6 weeks of sitting at home waiting for to be denied coverage, no, that doesn't seem like they're on an equal footing, especially when you have a parent who doesn't know what they're really getting themselves into, working against an organization whose whole purpose is to make rules and follow rules. So if the representative from NAMI would like to add to this,
well,
go right ahead.
Mr. Chairman, I'd like to speak to the proposed amendment. So one of the reasons we changed our bill this year is because we heard from the plans that they didn't want to do that kind of big paperwork analysis, although it is being done in other states. And so we went back to have just the kind of core pieces of information that they already collect. And I know that some of you are new, and I don't often come to Commerce, but we are known for working out compromises with people. We are known for taking on very deep, difficult issues and figuring out how to move forward. But I'm going to tell you that I've spent 2 summers asking the plan, saying you don't need this legislation to come forward, task force, to really talk about what data you can provide, and they did not do that. And so I'm feeling like we have tried. We have come together with, with language we could work on, but we hear these stories every single day, and we're just not willing to wait any longer. And the data that we're asking for in the amended bill is information that they already have.
Representative David, you would like to speak to what I said?
Both,
Both.
actually.
Go for it.
Thank you, Mr. Chairman. First of all, this bill is not a compromise. This is not a compromise. When one side is heavy-handedly pushing against another, that is not a compromise. And that's exactly what's happening here. Okay? There's no compromise here. But we need to get back to the question and to the chairman's comments. Current law is not being enforced. Do we have to pass a law that says, oh, we really mean it? We should do this? The law is there. It needs to be enforced. And last year, when this working group was put together, and it was in the final bill that the governor vetoed, that's the approach we need to take. We need to have a balanced approach where both sides have something to say. They both get to say, this is a very heavy-handed, one side. I want everybody to win. We need a win-win, and it's not happening with this bill. And if this amendment doesn't go on, this bill doesn't happen.
Are there any other questions for the testifiers? Oh, Representative Swazinski.
Thank you, Mr. Chair. Just a kind of a comment to maybe the Commerce Department. It sounds like, your fear or not worry potentially with this is that some of the plans are concerned about their, talking about potential secrets or kind of the way they're going about their business in a public forum, and you feel that some of those, is there a way that you could maybe produce a document that, from a blind side where we're not hearing exactly from which they are, so they can hear their comments, so that maybe that could be part of the solution, assuming Representative David's amendment goes on, or, is there, you feel like, in a public forum, maybe they're not going to be as free to speak, and, what are your thoughts along those lines?
Mr. Chairman and Representative, appreciate the question. I think that's what we're actually doing right now. I think after the bill that was not enacted into law last year that would have established a similar kind of task force, the departments, Commerce and Health, started to reach out to the plans and have that very dialogue individually. I think we are conscious of not wanting to, violate that regulated entity conversation. And so we haven't broached the topic with plans individually about what do we produce after this, but I think the focus has been how do we improve the rate review process and the network review process that we conduct on an annual basis so that we have better information from the plans to inform whether or not the parity standards are being met, and to utilize the existing system that we have to provide some better window for the regulatory agencies into what's actually happening for consumers. Mr. Chair, I think the task force may not necessarily allow us to have that kind of conversation with plans individually because they will not be able to have the kind of direct conversation that they're able to have when we meet with them one-on-one. So long answer to your question, but Representative, I think we're doing that now.
Any other questions? Any other questions? Any final comments on your amendment, Representative Davids?
No, thank you, Mr. Chairman. I would just say that the argument that Commerce is making is a fallacy, that you have to have private meetings. You can't concurrently have a working group. That's nonsense. I'd appreciate member support.
All those in favor of the A1 amendment signify by saying aye.
Aye.
All those opposed? No. The amendment fails. Back to the original bill as amended. House File 1340. Representative Lien, did you have any final comments?
Thank you, Mr. Chair, committee members. I certainly appreciate the very spirited debate here today. And really, especially, I want to thank the families for coming out and sharing those stories. That's very heartbreaking. I have a good friend who suffers from mental health issues, and so I've also seen his family, go through a lot of these crises and situations. And You know, I would just say, I mean, the federal mental health parity law was passed 10 years ago. So we've had 10 years for the policies essentially to figure out how to work this out, how to provide the coverage and everything. And this is not mandating benefits. It's mandating parity in the way processes go in place for coverage. So I don't know that another government directive for them to get together and talk through this is completely necessary. I hadn't really seen the amendment before today. I know the health plans came into my office briefly the other day just to speak about it, but I haven't had real in-depth conversations about how this task force would look or anything. But again, if we're going to take governmental action here to help these families, you know, I don't know that a task force is the best way to do it, to continue to talk about this problem for another year. The health plans have this information. If it was given to the Department of Commerce, the department would better be able to enforce mental health parity. And, you know, just to speak to the issue that this is a one-sided conversation, well, in my mind, for the last 10 years, it has been a one-sided conversation. We have families who are suffering through crises, losing loved ones, not being able to get the help and the services that, quite frankly, they're paying for through health insurance premiums right now. So, members, I just would really appreciate your support on this bill. Thank you.
Seeing no further questions, the chair will renew his motion to re-refer House File 1340 as amended to the HHS Policy Committee. All those in favor signify by saying aye. Aye. Opposed, same sign.
No.
You're on your way.
Thank you, Mr. Chair, committee members.
I'd like to call up the author of 766. This will be done. Is there any further? I will take House File 766 off the table. There are multiple other committees meeting, and we all have to keep moving. I have a series of questions that I'll probably ask offline. So we have this House File 766 before us. Is there any more discussion? Any more discussion? Seeing none, the chair will renew his motion to re-refer House File 766 to the Ways and Means Committee with a recommendation that it be referred to the HHS Finance Division. All those in favor signify by saying aye. Aye. Opposed, same sign.
No.
You are on your way.
Thank you, Chair.
Do we have any more business before the committee?
It was a stupid creation, it was a stupidly implemented, stupidly used.
Members, we have,
Stupid program.
members, the audience needs to be quiet because we have further work to do tonight. We will be coming back to room 200 at 7 o'clock for I don't know which particular bill, but I'm sure we've all been talked to about it. Gotten a few emails about it. Okay, and I want, if you're a member of the public who is looking to talk, to watch the next bill at 7 o'clock, there is you'll have to get a ticket to get in. So bring your stuff with you. You will not be able to get back in the room without a ticket. Members, at this time, we stand in recess till 7 o'clock, room 200.